Good afternoon, ladies and gentlemen. We're about to get started. From the Arcadian Court in downtown Toronto, welcome to the Empire Club of Canada. For those of you just joining us through either our webcast or our podcast, welcome to our meeting. Now, before our distinguished speakers introduced today, it gives me great pleasure to introduce our head table guests to you. And I'd ask that each guest rise for a brief moment and be seated as your name is called. And I'd ask that the audience please refrain from applauding until all the head table guests have been introduced. So, starting with our guest of honor, Dr. Michael Apkon, President and Chief Executive Officer, the Hospital for Sick Children. Ms. Kate Crawford, Partner, Borden Ladner Gervais, LLP. Mr. Tony Van Strobenzi, Past President, Empire Club of Canada. And I just want to mention about Tony, my first experience as a young man at the Empire Club, when I came to my first lunch here ever, Tony was the president and had a certain Audrey Hepburn at the podium. It's a very memorable day. So thank you for being here, Tony. Ms. Sonia Jacobs, Vice President, Canadian Partnership, NRC Health. Mr. Nick Pasquino, Partner, Bordner Ladner Gervais, LLP. Mr. Ali Badrudin, Managing Director, Strategy Corps, and a Director of the Empire Club of Canada. Ms. Rose M. Patton, Special Advisor, BMO Financial Group, and past Chair, Board of Trustees, the Hospital for Sick Children. And my name is Gordon McIver. I'm the past President of the Empire Club of Canada. Ladies and gentlemen, your head table. On a cold spring day, 142 years ago, an 11-room house was rented for $320 a year by a Toronto women's Bible study group led by a certain Elizabeth McMaster. These dedicated women set up 6 iron cots and declared open a hospital for the admission and treatment of all sick children. Their first patient, a scalding victim named Maggie, came in on April the 3rd. 44 patients were admitted to the hospital in its first year of operation, and 67 others were treated in outpatient clinics. And so began the story of what was to become the Hospital for Sick Children, branded simply as SickKids fairly early on, a healthcare community dedicated to excellence in the compassionate care of children and their parents. 28 years after the hospital's initial setup, the Empire Club of Canada was born, a speaker's podium set up by a group of men who did not want Canada to become part of the United States. For the first decades of our history, there is no record whatsoever of SickKids in our archives. Probably not surprising, as it was still a small hospital that was still unaware of the vital role that it would play in later years in the history of our great city and country. Now, by the time the hospital located to its present location on University Avenue back in 1951, building on the very spot where America's greatest movie star of the silent era grew up, and of course I'm referring to Mary Pickford, dubbed America's sweetheart, although she was Canadian, we began to find the hospital mentioned in speeches delivered at this podium by our guests of that era. In 1986, we of course had one of our most legendary Canadian artists, Robert Bateman, speak to us, and he actually made national news across the country by donating one of his masterpieces to the hospital so that it could be auctioned off, and it was at the highest price ever received for a donated work. 3 years later, we welcomed the president of the Hospital for Sick Children, David Martin, to our podium, and he gave a speech entitled "Swallowing the Bitter Pill," which focused on the difficulty that politicians of the era were having with the concept of co-payment. And this speech led to considerable discussion on funding of the medical community in Ontario, and of course cemented the relationship between the Empire Club of Canada and SickKids. Fast forward to 2017, and we're now dealing with what has become the most famous and iconic medical facility in our nation, a hospital that parents around the world who have sick children have come to know, to respect, and even to love. And once again, it is poised to grow and expand, ensuring that Toronto continues to be a center of excellence for pediatric medicine and research. Our speaker today has the impressive responsibility of overseeing what will be one of the largest fundraising exercises in the history of Canada. And he has everything in his background and personality to ensure that this campaign will be entirely successful and will lead to a solid and bright future for the institution that he heads. Dr. Michael Apkon is a physician executive and physician scientist who has served in C-level leadership roles at several top academic hospitals in the United States and Canada. He has been the CEO of SickKids since January of 2014. In that capacity, he leads a 300-bed hospital staffed by 10,000 employees, scientists, medical staff, students, and volunteers with a $1 billion budget. SickKids is recognized as one of the world's top children's hospitals, as we indicated earlier, and is Canada's most research-intensive hospital, a highly successful clinical, educational, and research organization. In addition to his role at SickKids, Dr. Apkon chairs the Ontario Provincial Council on Maternal and Child Health, a provincial program of the Ministry of Health and Long-Term Care, aiming to foster the evolution of a more effective provincial healthcare system for women and children. He also serves as the director of Mars Innovation, a commercialization cooperative and incubator for the life sciences and technology industries in the Greater Toronto Area. He's had extensive international management experience in both pediatric and adult-oriented healthcare, working with organizations and governments in the UK, Europe, China, Africa, and the Middle East, as well as, of course, North America. He's consulted widely on business development, capacity development, and management systems, as well as quality and safety improvement. He's an expert in strategy, systems development, and operations management, as well as the application of lean and high reliability organizational thinking to drive improvements in quality, safety, and efficiency. Now, Dr. Apkon originally hails from the United States, but we know that he's come to love his new home in Toronto. And if his world-class facility can be built on the site of what was the childhood home of a Canadian girl who became America's sweetheart, we know that he, in turn, can become Canada's medical hero for children, running a hospital that now truly belongs to and serves the entire global community. We're delighted to have SickKids Hospital back with us again at the Empire Club of Canada, and so I'd like you to please join me in a warm round of applause as we welcome its incumbent CEO, Michael Apkon, to bring us up to speed on his organization's very exciting and somewhat formidable plans for the next decade. Ladies and gentlemen, Dr. Michael Apkon.
Bonjour. Thank you, Gordon, for that really kind introduction. I only wish I had your voice. It's also wonderful to see so many colleagues, supporters, and friends here today, and I really thank you for taking the time to be here. I'm deeply honored to speak before the Empire Club of Canada, and I've come to appreciate your rich tradition, and I'm humbled to have an opportunity to share my perspective on children's health and the importance of investing in Canada's future. If you'll indulge me, I'm going to try to consider this a belated commentary on National Child Day, which is celebrated every November 20th since 1993 to commemorate the UN signing the Declaration on the Rights of the Child. So I believe I speak for many of you when I say how very fortunate we are to live and work in one of the most highly developed and most affluent countries in the world. And although there's considerable disparity in wealth across geography and across socioeconomic groups, the mean per capita income here is high, and we have perhaps the wealthiest middle class. I also feel fortunate to be a part of one of the most effective healthcare systems in the world and to lead an organization that sets the bar for specialized care for children in Canada and globally. I also take great pride and comfort in being part of a healthcare system that's built on the principles of equity and equal access for all. And I've always been deeply troubled by the inequities created in my own home country south of the border by the high cost of healthcare, many people's inability to pay, and what that means for the most voiceless and vulnerable. So I wear a lot of hats these days, and they're all important, but there are a couple that define me more than others. I'm a physician, specifically a pediatrician and an intensive care specialist, and I went into medicine because I wanted to make a difference in people's lives. As a physician, I've had the privilege of witnessing and being inspired by the miracles of modern medicine, and I've also had the experience of helping some families through the most challenging and unimaginable experiences of coping with times when medicine isn't enough. I'm also a physician who today chooses to spend most of my time as a healthcare executive, not because I wanted to move from the bedside, but because it was a means to an end, the end being better care and greater impact. Maybe the most important hat I wear, though, is the hat of being a dad, filled with the hopes and dreams that every parent has, as well as the anxieties of parenthood, praying that my kids will stay healthy and happy, as I'm sure all of you do. I can say that the way I think about being a physician and a healthcare executive has been shaped immeasurably by wanting every parent to have the joy that I've had from my kids. Since being a parent, I can also say that I feel other parents' fears and anxieties much more clearly, and that has an impact in the way I carry out my day-to-day roles. I've spent my career working to make our systems of care better and safer for children that need our help. As a society, we spend a lot of our treasure on healthcare, and we work to increase the health of our citizens. In fact, on a per capita basis, we spend $6,600 per person per year, roughly speaking, more than 11% of our gross domestic product, more than most of the countries in the Organization of Economic Cooperation and Development. I was speaking at an event last week and was asked whether I thought we received good value for our healthcare system, and in many ways, maybe the most important ways, the answer clearly is yes. Over time, we've seen remarkable progress in improving the lives of Canadians. Mortality rates for children under 5 has fallen by 85% since 1960. And over the same time frame, life expectancy has risen from barely over 71 years to 82 years. It's among the highest in the developed world and longer than the 79 years in the U.S., despite their spending far more per capita on health care. We attract visitors from all over the world who hope to learn from what we're doing well. Last month, Toronto hosted Senator Bernie Sanders, as well as a delegation from the Dutch healthcare system, hoping to see what they can take back to their own countries as they seek better value in their own healthcare systems. Despite having a lot to celebrate, though, we do face a number of challenges that aren't unique to Canada. We face rising expenses driven by new technology, treatments, and complexity. We have a limited ability to raise revenues to address those expense increases, even in an organization like SickKids, which has benefited from the incredible generosity of our community that's been inspired by our message. There's always room for more ideas than there is funding for. We also, as a system, face ever-increasing demand from patients and families, demand for better quality, safer care, greater convenience, more equity, better outcomes. Particularly as information becomes more accessible. Despite universal access to services, we still experience considerable disparity when you look across socioeconomic groups or between Indigenous and non-Indigenous people. For example, whereas infant mortality in Ontario is roughly about the same as the Canadian average, the mortality rates are much higher in the Northwest Territories and almost 4 times higher in Nunavut. Recent studies by Astrid Gutman from SickKids, as well as the Institute for Clinical Evaluative Sciences, or ICES, demonstrated significantly higher childhood mortality from respiratory infections in more socioeconomically deprived groups. The rate of suicide among youth in Ontario's northernmost regions are almost 8 times the rates in Toronto, and even higher in some communities. We also know that some countries deliver what seems like even better value, slightly longer life expectancy, better performance on other measures that matter to people at the same or maybe even lower cost. So to be sure, it's pretty tough to compare performance of our healthcare and social care systems without considering the complexity of genetic factors, environment, lifestyle, and many other contributors to health. And I've also learned that there's no perfect system, just different trade-offs. I'd submit that the critical question, though, isn't how do we compare, but rather how can we do better? How can we ensure that every Canadian child has the capacity to fulfill their and their parents' every hope and dreams? There's no doubt that we can do better with the will and with the focus. There are many, many opportunities to enhance value and engage improvement in our system, but I want to propose, however, that one of the most important and urgent opportunities is to improve the health and well-being of Canada's children. While there are many strategies that we could use to do so, I also believe that we need to identify a unifying objective to drive change most expeditiously. In the time I have left, I want to share with you why I believe that addressing children's health is central to the sustainability of our healthcare system, And I want to suggest several specific strategies, including examining the way we look and configure our healthcare system, and most importantly, I want to suggest a unifying objective, a bold moonshot, if you will, to significantly reduce children and youth mortality as a way to organize our thinking and to gauge our progress. There's at least 4 reasons to focus on children's health. The obvious argument is the moral argument, that we have a moral responsibility to care for our most fragile and voiceless citizens. Second, better health care for today's children will also contribute to a more secure future for today's adults. The birth and fertility rates in Canada are far lower than the so-called replacement level needed to compensate for society's rate of dying. We need to raise children to be productive tax-paying adults, and we should see the investment in Canada's children as an existential issue if tax-paying Canadians are going to continue to provide the social safety net that we rely on as we age. Third, better health care for today's children is also a key to having a sustainable health care system into the future by reducing the cost of caring for people into adulthood. With health care costs that are threatening to bankrupt government treasuries and a great burden of adult health care costs driven by conditions and lifestyles that are formed during childhood, investment in Canada's children is an important driver of long-term economic health. Consider the fact that 50% of all cases of mental illness across all ages first present in childhood. Children with disabilities and healthcare needs become adults with disabilities and healthcare needs. Adult obesity, diabetes, and cardiovascular disease have their roots that begin as early as infancy. Finally, poor child health creates an economic and social burden on families, including the siblings of sick children, that contributes to poor long-term educational attainment, less economic success, and social deprivation that contaminates healthier siblings and spreads the impact across families and across generations. When you consider the direct impact on health, the economic benefit of healthier adults, and the amplified impact of families by relieving the burden of childhood illness, there's an incredible leverage in making investments in children's health care that I believe far exceed the kinds of returns that we see on other social investments. If we're going to enhance health value, though, and enhance value, extend life, we need to understand what drives health and well-being. Although I have a vested interest and probably a bias towards the impact of healthcare delivery, the truth is that healthcare delivery is a relatively small contributor. Genetics are a big contributor and explain maybe 30% or so of the differences or variation in health across different populations. Lifestyle and behavior is an even bigger contributor, accounting for maybe 40% of health differences, and it's important to recognize that many of the important factors are defined in childhood. Eating, exercising, smoking, drinking, all those habits start pretty early in life. Social circumstances make up 20%, about twice the impact of healthcare delivery. So housing, transportation, poverty, and education all are big contributors and impact the likelihood of being sick, the ability to get help, and the ability to cope with injury and illness. So I did say that healthcare isn't the major driver. Nonetheless, it is one that carries an awful lot of weight. It's part of the broad social care system that sees the opportunities, has a lot of the complicated and sophisticated management and governance systems to drive change, and also has expertise in problem solving and knowledge translation. Involving healthcare systems, and specifically hospitals, seems to be a key success factor, and indeed other jurisdictions leverage healthcare systems to drive broad change. Saving lives depends on understanding not only the causes of death, but the important contributors which serve as some of the most effective targets for intervention aimed at preserving life. And it's important to realize that the approaches change over a child's lifetime, and the opportunities start before a baby is even born. Prematurity and birth injury are important contributors to mortality in the first 24 hours of life and a significant cause of lifetime disability. 3 of the 4 top risks identified by the Health Insurance Reciprocal of Canada relate to the care of pregnant mothers and the delivery of their babies. Birth injuries to babies are one of the top reasons for insurance claims for both hospitals and doctors. Contributors to prematurity and birth injury are clearly complex, and they're not simply a reflection of healthcare delivery. Living in rural communities, poverty, teen pregnancy, substance abuse are all important potential contributors. However, the healthcare system can build systems of care that distribute expertise more effectively, build capacity in remote centers that don't get a lot of practice with the kinds of emergencies that lead to harm, and help educate providers and the public to improve prenatal care as well as labor and delivery services. For infants and young children, disease becomes a major cause of mortality and morbidity. For children, cancer is responsible for approximately a third of all deaths under the age of 14, and it remains a major cause of death in childhood, despite the survival for children with cancer in North America increasing from 10% to more than 80% over just 50 years. There continues, though, to be considerable room for improvement, and 1 out of 5 children still dying from their cancer has to be unacceptable. Moreover, childhood cancer treatments cause considerable long-term morbidity that influences adult health, including the potential for secondary malignancies during adulthood. And we need to continue investing in new cures and improved therapies for childhood cancers, as well as research into the causes and long-term consequences of childhood cancer. Similarly, we have to continue investing in research, seeking to change the course of the inherited and acquired diseases of childhood that are responsible for nearly 20% of the rest of childhood deaths. Emerging technologies such as gene therapy, regenerative medicine, and tissue engineering, all of which are current realities in at least some limited way, hold the promise of a very different outcome for children suffering lifelong and life-threatening medical conditions. Just recently, really in the last couple of weeks, we saw a paper describing a child cured of a terrible and life-threatening, often life-threatening skin disease. He was cured by taking a small piece of his skin, curing that little piece of the genetic defect that he suffered from, growing that piece into 9 square meters of skin, and then through a series of skin grafts, replacing his diseased skin with the now normal version of his own tissue. Here at SickKids, we announced, together with our partners at Mount Sinai, the first Canadian repair of a spinal deformity called spina bifida, while the baby was still inside her mother. That repair at 25 weeks of pregnancy likely prevented the kinds of complications that can cause a lifetime of medical difficulties and early death. Expanding on these kinds of successes and bringing the promise of new advances to fruition requires a pretty ambitious research agenda and appropriate investments in supporting translation of science from discovery to recovery. SickKids is clearly an organization working to increase our impact in all of these areas, and I think among the best poised in the world to advance a number of these areas, including the regenerative potential of stem cells. Beating back the scourge of disease, however, isn't by itself sufficient. Death and injury by accidents is a major factor, even in infancy, but it increases in importance as kids get older. Death by accident and suicide account for half of deaths in Canadian children under 14 and almost 80% in teens between 15 and 19. In that older age group, suicide accounts for nearly 30% of deaths. The factors contributing to accidents or the failure to prevent a suicide are complex, but we have to consider these deaths preventable. We know that affluence and poverty are important factors, with traumatic injuries significantly higher in the poorest fifth compared to the more affluent parts of society. And this is particularly important given that 1.2 million, or 17% of Canadian children, live in poverty. Although healthcare delivery itself is unlikely to be the most important driver of death and injury improvements, better healthcare delivery absolutely would help. Many of you are likely aware that preventable deaths in hospitals are all too common. Medical error is considered the 3rd most common cause of death in the US, and I don't think it's much different in Canada, and kids are at particularly high risk. Regardless of how good hospitals and other providers are, some harm actually happens as a result of care, whether it's by mistakes or by complications that aren't effectively prevented. As good as SickKids is, and I do think we are very, very good, we know that there are circumstances where children suffer harm within our walls. And although we don't necessarily know how to prevent every mistake, we do believe we have a moral responsibility to see what we can learn and to work hard to get better and better. That's why 3 years ago, we made a commitment to reduce preventable harm by 2/3 over 3 years by committing to more reliable practice, better teamwork, and to learn from our failures. The approach we took isn't particularly novel, but it also isn't particularly easy. It does work at SickKids and many other organizations that have followed a similar route, and we've reached our goal sooner than expected. We're working hard to go even further and to share what we've learned with other partners. Systems of care are also important and are particularly important for children. It's not reasonable to expect that every healthcare providing site provides all things to all people. The more specialized the service, the fewer the people that need it, and the more it tends to be concentrated in a few centers. Because specialization tends to lead to better outcomes for certain surgeries and treating certain diseases, we leave people having to choose between quality and convenience, particularly when they don't live next door to the kinds of centers that we're so lucky to have here in downtown Toronto. Care for children is particularly highly specialized, and that specialization we know makes a difference. Children are twice as likely to survive life-threatening traumatic injuries when they're cared for by specialized pediatric trauma teams. It's pretty challenging to provide expertise, though, when it's concentrated at very few specialized centers. 85% of kids come to their local emergency department rather than a children's hospital when they need emergency care. And yet it's uncommon to find children's doctors or nurses in these local emergency departments. We know that the likelihood of surviving a life-saving emergency is better and higher in a specialized center and in centers that see a lot of kids compared to those that have fewer visits. SickKids, as an example, sees nearly 80,000 children a year in our emergency department. In contrast, other hospitals in Ontario that see as few as a few thousand or even less. Kids also can't come to urban centers where the specialized hospitals are every time they need to see someone for their mental health or for a clinic appointment. Kids with complex needs also need to be supported in their local communities, in their home communities, rather than having to relocate to urban centers where specialized resources are more accessible. We have to invest in efforts to share expertise from specialized centers with those caregivers and health centers that are the points of first contact and the critical safety nets for children who are ill or injured. It's important that we begin thinking about networks of care that bring together, with some form of common governance and accountability, hospitals that span a continuum of services and a very broad geography. These networks can facilitate planning, knowledge translation, and coordination in ways that distribute expertise and share care responsibilities much more effectively. It's interesting to see the UK's national health system organize 15 academic health science networks to cover the country and act as facilitators to drive change and drive improvements and facilitate knowledge translation across a full continuum of services, from home to very advanced care settings. It's also interesting to watch the networks that are developing in southwestern Ontario around London's Health Science Centre and the network in the Hamilton area around St. Joseph's and Hamilton Health Science. Networks can help leverage the management structures, governance, and enterprise systems that are so well developed within the largest hospitals and create a more effective approach to driving a holistic way of caring for larger populations, something that I know the local health integration networks are very intimately involved in trying to drive as well. Networks also can forge more effective connections with parts of the social care system. Cincinnati Children's, one of our peers in the U.S., is one organization that has leveraged their network to support school-based health clinics and health supporting connections with other sectors, including even fire departments, home care agencies, and many others. Beyond health care delivery, efforts to make care generally more accessible will also help. For example, reducing the financial burdens through programs like Ontario's OHIP Plus, Children and Youth Pharmacare program, will promote equal access to health-sustaining medications. So I've already mentioned a number of ways through which we can help children grow into productive adults, and clearly there's no end to the investments that might be helpful in improving health and well-being for children. SickKids is working hard to do everything we can to have an even bigger impact. I mentioned the work that we're doing to improve safety. Our scientists are working hard to find new treatments for cancer, neurologic disease, heart disease, and many other conditions. A major part of this is embracing the power of data, the power of genomics, and the power of regenerative medicine to better understand disease and to save lives. And we're working hard to expand and improve mental health services through telepsychiatry and through the integration of the Hinks-Delcrest Center, now the SickKids Center for Community Mental Health. With the support of the provincial government, we've also created an alliance, the Kids Health Alliance, with our partners at the Children's Hospital of Eastern Ontario and Holland Bloorview Kids Rehabilitation Hospital. The purpose of Kids Health Alliance is to collaborate more effectively between us and to enlist and engage like-minded partners like Markham Stouffville Hospital in improving the care of children closer to home, particularly in emergency departments. We have a lot to share, and we've been fortunate to be supported by philanthropy and the Government of Canada to share what we've learned with partners in Africa, in China, and other parts of the world. For those of you that have supported us, and I know many of you are in the room, thank you. Our Versus campaign to rebuild SickKids is a bold campaign to change the future of pediatric health care and the experience of children that face injury, illness, and recovery. We also know that there are many agencies, organizations, and individuals that are working to make important differences in your own ways. When we think of all the ways we can collectively have an impact, I have no doubt that different stakeholder groups are going to see opportunities through different lenses and debate the relative benefits of addressing prenatal care, or poverty, or education, nutrition, mental health, equal access, improved health care delivery, or better treatments. They're all relevant. We can also expect that each stakeholder that you engage in the discussion may well have a different measure of success in mind: less income inequality, better educational attainment, whatever is most relevant to their perspective. For policymakers, government, and even for those intimately involved in improving our systems, it's pretty difficult to decide what to address first or to decide how to compare the relative impacts of competing projects. We need an organizing theme, a way to keep track. We also need to be clear where we're going, with an ambitious target that would bind together various stakeholders and perspectives under one umbrella. In 1960, U.S. President John F. Kennedy called for an effort to put man on the moon within 10 years. Kennedy recognized that a moonshot was an organizing theme that would advance many different areas of science and technology, as well as achieve an important strategic objective. It fostered a new age of innovation that not only achieved its goal, but also spurred advances in many areas that have improved lives globally, and we enjoy a lot of that today. When we consider the complexity of improving the lives of children, we have to recognize that efforts to reduce mortality will benefit in immeasurable ways beyond saving lives. If we want to reduce, for example, the number of children that die from suicide, we have to improve better access to more effective services for many, many children, and that will improve the lives of those countless more children than only the children whose lives are saved by those efforts. So I've always been struck by the words of Dr. Don Berwick, the former Chief Executive Officer for the Institute for Healthcare Improvement and the former head of the Center for Medicare Services in the U.S. Don was famous for saying, "Some is not a number, and soon is not a time." I believe that if we want to make an important impact, we need a lofty goal, specific and time-bound. We need a child well-being moonshot, achievable yet ambitious. If Canada were able to reduce its childhood deaths to the average across the G7 countries, deaths would fall by 15%. Were we able to reduce deaths to the average of all the OECD countries that are higher ranked than Canada at the number 19 position, we'd have 30% fewer deaths. Based on the examples of what's been achieved in peer countries and assessment of the trajectory of improvements that we're already enjoying and my rough assessment of the contributors to child and youth mortality, I want to propose that government organizations, researchers, and clinicians work together to take on the ambitious but achievable goal to reduce child mortality by 30% in 5 years. The point isn't the target. Ultimately, we should be aiming to eliminate childhood mortality, but let's not negotiate the ultimate goal, although we're going to have to negotiate the timeline. The point is not the time. We simply need to identify a time frame that's short enough so that we're not delegating the responsibility to future generations, and long enough so that we can see some real impact. The point is not even the objective, but we do need some way to create a big enough tent to engage critical stakeholders in an objective that's undeniably relevant, measurable, and improvable. The objective of saving lives ought to be relevant to everyone interested in mental health, healthcare disparity, children's health research, or the social determinants of health, such as poverty or education. Kennedy said in his address at Rice University, "We choose to go to the moon in this decade and do the other things, not because they're easy, but because they are hard, because that goal will serve to organize and measure the best of our energies and skills, because that challenge is one that we're willing to accept and one we are unwilling to postpone and one we intend to win." I want to close by suggesting that we need the same lofty ambition, the same single-minded focus, and the same challenging trajectory if we want to significantly advance health and well-being of Canada's children. That lofty ambition, again, is to reduce childhood mortality by 30% over 5 years. That would mean saving 1,000 children a year across Canada. On my recent visit to Johannesburg, South Africa, to work with our partners at the Nelson Mandela Children's Hospital, one of which is here in the audience today, I was reminded of Mandela's words. He said, "There can be no keener revelation of a society's soul than the way in which it treats its children." I want to ask each of you to hear these great leaders and to build on the principles of social justice that form the foundation for Canada's healthcare system to invest in our children's health and Canada's future. Thank you. Merci à tous.
Ladies and gentlemen, Dr. Apkon has kindly agreed to entertain some questions, and we actually have 2 roving microphones at the back of the room. So if anyone has a question, please just raise your hand, and they will come over and hand you the microphone. It's a very shy group today. Well, while people are plucking up their courage, I actually had a question. What would be the hospital in another country that is most like Sick Children in both its governance and the services it offers?
So, thank you for that question. SickKids is organized like many of the other great children's hospitals around the world, in that it has an independent governing body that helps guide the children's hospital's strategy and holds management accountable. I would say our closest peers around the world would include places like Great Ormond Street in London, after which SickKids was actually created in some ways. In the United States, places like Boston Children's Hospital, the Children's Hospital of Philadelphia, and Cincinnati Children's would be the organizations that we would see as our peers. What distinguishes those places from many other healthcare institutions and other children's hospitals is the ability to bring clinical care at the very highest level that is doing everything that today is possible, but also seeing the gap between what we have and what we need, and then having the power of the kind of research institute that we have at SickKids to find creative solutions to that gap, and then put those solutions into reliable practice through the educational programs that we have, which train not only the next generation of Toronto and Ontario's pediatric healthcare providers, but through the partnerships that we have and the training programs that we have, spread that knowledge around the world.
Okay, yes, sir, go ahead.
Hello, sir. This is Rakesh from Cadillac Fairview. We are discussing a lot of post issues, like how we are going to deal with the issues. But my basic question is how we can address most of the health-related issues by making children more aware at the schools, like, including those small things like drinking water in the morning. Those basic things, how we can inculcate in our children, which are, can have future benefits from the school curriculum? Thank you.
So if I understand your question, you're asking how can we promote healthier activities and a healthier way of life by intervening much earlier in a child's life. And I think that's a really important question, and actually an important question to answer as part of an approach to reducing childhood mortality and improving well-being. And I think one of the, so number one, I don't think there's a simple answer to that question, and I wouldn't purport to be an expert in the educational system. But what I do see as being helpful when I look at other jurisdictions and even in other parts of Canada, including parts of Ontario, is the connection between the healthcare system and the social care system that help drive an agenda about what are the important things to educate about. How do we reach the people of influence around a young child's life, not only their parents, but educators, their local healthcare providers, to be able to have a collaboration that's aimed at reaching whatever lofty objection is established, whether that's promoting earlier reading or whether that's promoting healthier lifestyles. And I think what is beginning to happen in other jurisdictions is a blurring of the lines between health and other parts of the social care system. I mentioned the collaboration in Cincinnati Children's. They're working with all kinds of public-facing agencies in communities to try to identify what are the changes in lifestyle behavior, access to public services that would allow a child to not become ill and have to come to hospital. And I took the statistics out of my talk in the interest of length, but that group recently published a manuscript that has had a lot of press, where their public partnership across many different types of organizations, including school systems, were able to put together a number of interventions that reduced the hospitalization rate for children with asthma, a life-threatening condition of childhood, by 40% in the most impoverished socioeconomic groups in their region. And it was a partnership that blurred the lines between health and the social care system. And I think that's part of what's necessary to drive the right kind of dialogue to address the kinds of issues that you've raised.
We have a gentleman over here.
Hi, Dr. Apkon. Abdul Rahim from SickKids. I do have a question for you something that came to mind, probably from a thought that we're probably in the back end of the OECD countries, primarily because of our 14 provinces, right? And so nobody is willing to take accountability in moving healthcare forward, which makes it very difficult to pass either legislation or new efforts such as building an EHR system that has been much easier in other countries. So in moving forward with a moonshot goal, how do we build accountability not only on a local level, but throughout the cascade of our provincial regulatory authorities, where we can have a sense of metric that people are held accountable to so that we can see progress moving forward, which I think is one of the biggest challenges here in Canada.
Yeah, so I think your question is a good one, and I would say there are challenges here. There are also things that make it easier to organize the healthcare system and the connection between healthcare and social care in Canada compared to many other countries. And particularly if I look south of the border, where there's much greater degree of fragmentation and less governance and accountability around concepts like population health. And I think one of the things it takes is alignment around a common objective. And that's in part why I've proposed this idea of a moonshot focused on mortality. It's a measurable, relatively quickly movable metric that actually can be examined based on geography or socioeconomic population or by disease, a child's condition. And so there's a lot of ways to kind of slice and dice that data to get insight into what things might make a difference. And it's also the kind of thing where you can distribute the responsibility across different communities in different ways. To address the issue, though, we have to start thinking in ways that blur our organizational and sector boundaries in some way. You know, I was at a talk at the OHA Health Achieve meeting a couple weeks ago. One of the speakers was Dr. David Nicholson, who used to run the NHS, and he was talking about governance in the age of healthcare transformation. And what he said is, if you want that, you have to organize your governance to get the kind of system that you want. If you want to address the health of populations, you need to think about governance and accountabilities that span populations and address the set of services that they need to have. Now, I think there's lots of ways to do that beyond formally kind of amalgamating governance, and the Kids Health Alliance that we've created is one way to create a strategic alignment and accountability among partners that commit to working in a particular way to advance, a specific agenda. So, I think that it's the boundaries that sometimes get in the way, and however we can transcend those boundaries is going to be a part of the issue. And that includes, to address your thought about different provinces, different territories, that also means across provincial and territorial boundaries. There is no way for Nunavut to support the kind of specialized services that we have in Ontario. There just is no way to do that. And so the issue becomes, how do you extend the specialized services from Toronto and Ottawa and Winnipeg and other centers that have specialized services for children into the north? We do that through telepsychiatry now. We support poison centers at SickKids for other provinces. We need to do that more. I think there are ways for both federal and provincial governments to help, and some of it is organizations being willing to take on the mandate, and the other part is the people who need to partner have to look at places like us as being able to help and being willing to help, as opposed to the division of responsibilities being narrowly defined.
Thank you very much.
Thank you.
Thank you. Ladies and gentlemen, please welcome Kate Crawford to thank our esteemed guests today.
Thank you, Mr. McIver and Dr. Apkon. As was just mentioned, my name is Kate Crawford, and I'm a lawyer at Borden Ladner Gervais, which is a law firm. I'd like to thank Dr. Apkon for his thoughtful presentation. We at BLG are proud of the special relationship that we enjoy with our hospital clients, and in particular with SickKids, with whom we have worked for over 60 years. We aim to deliver strategic legal advice and hope to help our hospitals protect their operations, to mitigate risks, and most importantly, to move forward in the bold type of initiatives aimed at achieving the outcomes that Dr. Apkon described today. I've had the great pleasure of working with Dr. Apkon and many of the outstanding team members from SickKids who are here today on several occasions. We're very pleased to be here today to sponsor this event, and even happier to be working with the SickKids team. The leadership displayed by the hospital on both a macro and a micro level continue to impress us at BLG despite our long-standing relationship. Today, I listened carefully to Dr. Apkon's discussion of challenges facing the delivery of healthcare, including poverty, access to the north, and costs, and what SickKids proposes to do to address these challenges. Let us respond to Dr. Apkon's call to arms to enhance and improve the health of Canada's youth. BLG is proud to be a supporter of SickKids, and we look forward to our contribution to this objective. Thank you again to Dr. Apkon and to the hospital, and thank you to all of you today for attending.
Thank you, Kate. Thank you so much, and a sincere thank you as well to, obviously, to our sponsors, Borden Ladner Gervais, and to NRC Health for making this event possible today. Without sponsors like these great companies, the Empire Club lunches would not be possible, so we very much appreciate your sponsorship. We'd also like to thank MediaEvents.ca, Canada's online event space, for webcasting today's event for thousands of viewers around the world. Now, although our club has been around for well over a century, since 1903, we have moved into the 21st century and are very active on social media. So we invite you to follow us on Twitter at Empire_Club and visit us at empireclub.org. You can also follow us on Facebook, LinkedIn, and Instagram. Finally, please join us again for our upcoming events. We're having quite a season this year. I think we have events almost every day this week and next. We're actually sold out tomorrow for Andrea Horvath, but I do want to let this audience know about an event next week because it is germane to the folks in this room. On November 27th, we will welcome Rob McEwen and Dr. Michael Laflamme at 1 King Street West, and they will be addressing the future of stem cell research in Canada and its impact on our future well-being as Canadians. So that concludes our meeting today. Thank you very much for your attendance, ladies and gentlemen. This meeting is now adjourned.